Imagine the power of research in emergency medicine, where we can advance the science and improve outcomes for almost any injury or illness that walks through our doors. Whether that's in trauma or resuscitation, cardiac reasons, neurological events, overdose, addiction, we have the possibility to really affect change and improve care.
If you look at the national data, there's 140 million emergency department visits each year. And people that don't practice in the emergency department really don't understand the limitations of our diagnostic and therapeutic capabilities and aren't motivated to solve those challenges.
When I was in medical school, emergency medicine was very new. And first month, fourth year, I did an elective in the emergency department. Within 3 days, I knew this was what I wanted to do.
I did not want to be organ specific. I pride myself as being an excellent diagnostician, not just of one organ or one disease, but patients as a whole.
I was interested in just about everything. Emergency medicine is a chance to enjoy scientific disciplines across the board.
I absolutely love taking care of patients. I also realize that taking care of patients can be highly demanding.
It's a tough job. It involves a lot of nights, weekends, holidays, time that you might have spent with your loved ones. And everyone needs something to keep them going, whether it's making a diagnosis for a patient who's been looking for answers, resuscitating someone who might not have otherwise made it out of the hospital alive. We all have to hold on to whatever it is that makes us want to get up every day and go back in for another long shift. For me, that thread has been research.
Initially, I did not have any interest in a research career. I absolutely love working clinically, and the frustrating thing I encountered throughout my residency and fellowship training was essentially that the evidence that I was basing decisions on was not as strong as I thought it would be.
We were doing CPR on somebody, and what we used to do routinely is we would go ahead and give intracardiac doses of epinephrine, on a big long needle, and we'd jab it through their chest and into their heart and give them the epinephrine. And I remember asking the question to one of the more senior people there, I said, can't we give epinephrine through an IV? He said, well, it won't work if you give it through the IV because it doesn't get there because there's not enough circulation. I said, do we know that? And he said, well, I don't know.
It's the research that informs these mental models so that when we walk into a room, we know exactly what to do.
50-year-old male coming from home. Sounds like he was last seen normal yesterday by his grandma. This morning his nephew went to check on him and found him semi-responsive on the ground. He does respond to his name, but he's not able to speak clear or concise. Senses, stroke scale is non-conclusive. Tachycardic 128, 12 lead was unremarkable. Slightly hypoxic, like 88-90%.
We need to know how to treat them and manage them, and we need to as well kind of know what the next steps are so that we can inform our patients what they may be encountering over the next 4, 6, 12, 24 hours, as well as engaging surgical specialties or medical specialties to help patients with these conditions that they're presenting with.
Sir, can you look over towards me, please?
The best care in the world that's delivered too late is useless, right? Our role in the House of Medicine is to make sure we get the best care to patients as quickly as possible.
However, there are a lot of things that we don't know. And when we close those gaps in knowledge, we are able to then take that evidence and integrate it into clinical practice guidelines, patient care protocols.
I'm probably best known for my use of buprenorphine for patients with opiate use disorder. And it seems kind of crazy when you look back on it and say, why didn't people think of this before? Or why didn't they do it? But really, they didn't have a burning passion to try and figure out a solution to a common problem that you see every day.
One of the things that bothered me the most was that 2 patients who looked identical could come into the ED, but one would get admitted to the hospital and the other person discharged.
As a resident, I was training during a rapid increase in opioid overdose fatalities and just seeing incredible deaths of young people.
One of the reasons I got so interested in developing a rule that could allow us to exclude pulmonary embolism at the bedside without diagnostic testing were all the arguments that I got in with my attendings when I was a resident, who the attendings were wanting me to order VQ scans on patients that I didn't think needed it.
I can't tell you how many times my colleagues will come to me and say, this really bothers me. And I'm like, wow, that sounds like a good research question if you would like to explore that. And of course, we all know that the best research comes from doing research that you're passionate about or understanding something more that bothers you. And so being in emergency medicine, you get to see all of these sorts of things.
We touch every part of the body. We touch every physiologic and cellular mechanism that's out there. And so the ability to be able to do research anywhere across the board and go where the data takes you, go where the problem takes you, go where the excitement is a huge advantage to emergency medicine research.
What we really are the experts on is in the first few hours of care of acute illnesses that other specialists do not see.
And that could be first aid, it could be the paramedics' actions, the first responders' actions, it could be what we do in the emergency department, spanning into the intensive care unit or onto the hospital floor or into what happens to the person after the visit to the emergency department. All of those are emergency care.
An emergency medicine doctor knows more about how to treat an acute asthma attack than a pulmonologist because we do it more.
We work on the clinical side with almost every other specialty in the hospital as well as every other ancillary service. And I often say this to my colleagues in other specialties, no matter what kind of patient you're looking for, I have seen them in my emergency department in the last year.
Everybody always wants to come to us to partner for research because we have become the home of acute care.
If you have a skill set that can be applied to multiple problems, you can go after multiple problems at once or in series, and you go to different funding agencies depending on what the problem is that you're applying your skill set to.
In the work that I do in cardiac arrest, so much of what we do integrates into other fields in the ICUs and cardiology and neurology.
I focus on transmissible infectious diseases. I have colleagues who focus on areas of hematology oncology, trauma, resuscitation science, basic science, pathology, radiology. And so we get the very unique opportunity to ask questions that touch upon specialties, both clinical and non-clinical. We get the opportunity to ask questions of policy and public health and population health.
A lot of times there's much more talk about the negativity because of the competitiveness of getting funding than there is really about the joys of working, especially in this interspace between research and clinical care. I think it's just a very fulfilling area to be.
We gave him urokinase and he walked out of the hospital. And it was like, wow, that was pretty amazing. So I was in the lab working in cell cultures.
I started off by meeting an emergency physician second year in medical school who got me started on a couple projects looking at the cost effectiveness of chest pain care. And what I did was I caught the bug. I loved it. I loved taking data, analyzing it, and using it to really push care forward. I felt like every time I did a research study, I'd had impact on not just the patients I had a chance to see during a clerkship, but I'd had an impact on maybe hundreds or thousands of patients around the country when that paper went to use.
I truly believe that by overlapping research and emergency medicine, there's an opportunity for great longevity. Not only do you have this opportunity to explore your interests and your curiosities, but you also have this opportunity to work in a space where you're constantly being exposed to the very patients that are going to help you to formulate some of your most interesting questions.
As a geneticist, we would do work that would take 15, 20, 25, 30 years before we would see any change, any positive impact, incremental science.
I think someone has once said the average time from novel research finding to improvements at the bedside is 17 years. I think that is much, much, much shorter in emergency medicine and probably on the scale of months, if that, because of how active emergency medicine is in taking what we learn to improve care. And so I think it's incredibly dynamic.
When I wake up and open up a spreadsheet or a new set of data about a clinically important problem, and I'm looking at these data and I'm starting to see an answer form that no one else knows. It is an incredible gift, an incredible feeling of power to have information that other people are going to want to know. But right now, at this minute, I'm the only person in the world that knows it.
It's not what I thought it was. It's not all bench and pipettes. It's systems, it's data sets, it's healthcare use, it's qualitative, it's community engagement. There's so much under that umbrella where you can make change and make impact that is truly exciting.
It adds a lot to your experience as a doctor.
If you're resilient and
you're passionate about an issue, you can do research. The writing, the grantsmanship, the statistical analyses, all of that, you can develop those skills.
And when you feel like you might be spinning your wheels and the research sphere, which certainly happens sometimes, you can sort of go work in the emergency department and sew up a laceration or provide preventative care for something that is like very, clear and easy and concrete.
There is space for you to become a leader, to make your mark, to have an impact.
It's a field that is in no way saturated, and everywhere there is a gap and a lack in our knowledge, it's our responsibility to try to fill that gap.
As an emergency medicine physician, I have come to understand that we are all foot soldiers. We are grinding along in the EDs, and that truly this is a tribute to our field, and that we absolutely will change the lives of individual people, but that we will not change the field by being foot soldiers. The way to change the field is by doing something bigger than your individual practice and taking care of individual patients.
So one research project I'm currently focusing on is addressing complex substance use during
CAT scans in children with trauma.
About running out of resources, and whether it was
Actually
ventilators.
not that great at diagnosing urinary tract infections. We turned that into a research question and also part of our protocol.
Study looking at Tamsulos for kidney stones.
Impact
so
of limited resuscitation.
Quantitatively how large it was so that we can begin to close the gap.
Changes in how we care for older adults in the ED.
We felt like that data should be interpreted here in the United States.
That molecule and see that under electron microscope.
Discharging folks from the hospital into safe
mechanisms
and
of brain
stable
injury caused by cardiac
As a
arrest.
result of that now, a bill was passed within the past year.
Continues to impact sepsis care today.
So this is our laboratory. The possibilities are endless. The questions are endless. You need to be down here to actually work with patients and formulate your ideas. Come and join us.